This is a portable chest radiograph of an elderly woman with a known history of mitochondrial myopathy, taken in the intensive care unit. The film shows a tracheostomy tube and a right subclavian central venous line in appropriate positions. However, the nasogastric tube is clearly misplaced. Instead of coursing inferiorly through the midline into the stomach, the tube is seen entering the left main bronchus, passing distally into the anteromedial basal segment of the left lower lobe, and then exiting the lung into the pleural space, with its tip projecting superiorly towards the apex of the left hemithorax. These appearances are diagnostic of a misplaced intrapleural nasogastric tube. There is no real differential diagnosis for this finding. It represents a malpositioned nasogastric tube that has inadvertently entered the tracheobronchial tree and perforated into the pleural cavity. This is an important and potentially serious iatrogenic complication. Such pleuropulmonary complications are the most common result of misplaced feeding tubes, particularly when they coil in the pharynx or are advanced inadvertently into the bronchial tree. The misplacement may occur despite apparently reassuring bedside checks, as traditional clinical methods such as air insufflation with gastric auscultation, aspiration of gastric contents, or absence of coughing are unreliable, especially in critically ill or intubated patients. Because of bronchial anatomy, right-sided bronchial intubation is more common than left, but in this case, the tube has entered the left side. If left unrecognized, this can lead to severe complications such as pneumothorax, empyema, or direct pulmonary injury. Management in this situation requires immediate recognition and communication with the clinical team. The nasogastric tube must not be used for feeding and should be promptly removed. It is essential to advise a follow-up chest radiograph after removal, as a pneumothorax may develop due to pleural breach, as demonstrated in follow-up images showing pneumothorax in similar cases. In summary, this radiograph demonstrates a misplaced intrapleural nasogastric tube, a critical finding that must be immediately reported to prevent serious pulmonary complications. The key learning point is that correct tube placement should always be confirmed radiographically, as bedside confirmation techniques are unreliable, particularly in ICU patients.